Cortisol stimulation test results: high ACTH, low AM cortisol, low serum cortisol after stimulation. Diagnosis for primary AI: adrenal insufficiency, low ACTH, low AM cortisol, normal cortisol after stimulation. Diagnosis for either secondary or tertiary AI. The adrenals can be stimulated appropriately and will respond by pumping out cortisol. That's why you're giving the cositropin. You're stimulating them. You're saying this is a secondary. Now we have low ACTH, low AM cortisol, low cortisol after stimulation. Diagnosis of either secondary or tertiary, but indicates long-standing adrenal insufficiency. This is likely adrenal atrophy because the adrenals are not responding to cortisol stimulation. Let's go through this again. So you have high ACTH, low AM serum cortisol. That is primary AI. We have low ACTH, low AM cortisol, normal cortisol after stimulation. This is secondary or tertiary AI. What about the patient has low ACTH, low AM cortisol, low cortisol after stimulation? Indicates long-standing AI, the adrenal atrophy, because the adrenals are not responding to cortisol stimulation. All right, let's go with a clinical scenario. This is a 34-year-old female who presents with 2-year history of progressive weight gain, particularly the face, neck, and trunk, along with hypertension and worsening glucose intolerance. She reports proximal muscle weakness, early bruising, and recent appearance of a wide purple striae on her abdomen and thighs. On examination, she has a rounded moon face, dorsal cervical fat pad. That's the buffalo hump. They may say that. They're not going to say buffalo hump. They're going to see dorsal cervical fat pad. And central obesity, thin skin with multiple ecchymosis. She also notes irregular menses and increased facial hair growth. What do we have here? Hypercortisolism. Now let's go real important. A lot of learners miss this. What's the difference between Cushing disease versus Cushing syndrome? Cushing disease is excess cortisol production during an ACTH secreting adrenal pituitary adenoma. Let's say this again. Cushing disease, excessive cortisol production due to ACTH secreting pituitary adenoma. Cushing syndrome refers to hypercortisolism from any other cause. What would this most likely be? Is iatrogenic. Iatrogenic, us idiot providers have given them too much steroids. Cushing syndrome, most common cause of the syndrome, not disease, iatrogenic in the setting of oral, intranasal, or inhaled glucocorticoids. Doses of 5 milligrams of prednisone or its equivalent are less likely to cause significant HPA axis suppression. But guess what? If you take these for longer periods of time, you will see some patients will be suppressed. It's not a maximum. Excess of 10 to 20 commonly will after 3 weeks or more. Remember, people don't read the textbook. Just because they're getting 5, you can go, you're receiving just 5 milligrams of prednisone. You cannot have suppression of your pituitary axis. No, that's not true, because anybody can. Everybody doesn't read the textbook. So, but in the 10 to 20, commonly after 3 weeks or more, you will. Let's go more in discussion on Cushing syndrome. Cortisol excess, best initial test confirms cortisol excess. Picks one, 24-hour urinary cortisol, free cortisol. Guess what? Collecting urine for 24 hours sucks, and it never happens, right? Because guess what? Say the patient does it at home, the lab will lose it. Say the patient does it at home, the clinic will lose it. Say the patient forgets to do it, that's normally what happens, okay? Say you do it inpatient, the nurses will lose it. You do it inpatient, the lab will lose it. It's never really done well. It doesn't happen well. 24 hours of anything does not happen well in the healthcare environment. 1 milligram dexamethasone suppression test or midnight salivary cortisol. Let's go through this algorithm. Suspected Cushing's, we do a screening test. The screening test is going to be plasma cortisol at 8 a.m. If greater than 2 after 1 milligram of dexamethasone at midnight, or 24-hour urine-free cortisol greater than 50, confirms Cushing syndrome. So we get an abnormal response, or we have an abnormal response to dexamethasone on the second day of 0.5 Q in the plasma cortisol greater than 2, or urinary-free cortisol. So we get to this, and then we measure the ACTH. So we know we have low, so then we measure the ACTH. So once we get the ACTH and we see it's lower undetected, We're going to do imaging. We're worried about an adrenal neoplasm, and we get an adrenal CT scan. So less than a 6 centimeter is going to be an adenoma, and we worry about a tumor greater than 6 centimeters is going to be a carcinoma. Coming over here, say the ACTH is elevated, we can do a high-dose dexamethasone test. If there's cortisol suppression, we would want to do an MRI of the pituitary. We're looking for pituitary secreting, and then we can look for a venous sample of looking for the pituitary for secretion. If there's no suppression, we worry about an ectopic tumor, and we would do a CT of the chest and abdomen. We'll discuss these more. This is just a brief overview. Remember, we have our deep dive lectures, and you can get more in-depth look at hypercortisol or hypocortisolism, and for Cushing's and Cushing's disease and Cushing's syndrome. Get a more in-depth look. Let's go on, and we're moving on. We have a 48-year-old female who presents to the clinic with complaints of increasing shoe and ring size over the past several years, as long as she has new onset joint pain and headaches. She reports her workers have commented on her changes of her facial appearance, including a more prominent jaw and coarse facial features. So she also has a change. Her coworkers are noting she smells differently. Smells like BO. Okay. On examination, patient has frontal bossing, where she has increased interdental spacing. She has enlarged hands and feet, thickening oil skin. Her blood pressure is elevated at 148/92. She also describes excessive sweating and more snoring in daytime somnolence. What does she have? Acromegaly. So what's the first test? What's the cheapest test that you can do? Is people don't realize that they change. You look at yourself every day. Maybe some people don't even look at themselves anymore in the mirror. When they look at themselves, you don't see those gradual changes. A coworker may notice, some people may not notice, even loved ones may not notice, because the changes could be so gradual. So what is the boards ask you to do is you check a driver's license photo. This is probably several years old, and you look for these changes. So acromegaly. So what would the changes in voice and sleep apnea? Because from growth of the cartilage, remember these are protein. Growth hormone makes IGF, which is a major, and this can cause growth of skeletal muscle. It can cause the hormones. It makes the cords in your neck thicker, and your soft tissues of your neck grow. This is why you can get the deep voice and sleep apnea. You can have a wide space. The teeth do the growth of the jaw. The teeth don't grow, so the jaw grows, but the teeth don't grow. Bad smell because of sweat glands and hypertrophy of the sweat glands. Prominent jawline of brow, so you can have facial edema. Spacing between the teeth and macroglossia. Remember, we talked about the teeth because the jaw is growing, but the teeth are staying the same size. Arthritis, skin tags, diabetes, hypertension, and colon polyps. More discussion on acromegaly. Can have visual field defects with headache and cranial nerve defects. Hyperhidrosis, which is excessive sweating, skin tanks, carpal tunnel syndrome. Melanomas can be growing faster and larger. Cardiomyopathy, hypertension, elevated heart rate, and valvular disease. Sleep apnea, narcolepsy, colon polyps, colon cancer, because IGF-1 increases our risk for colon cancer in elevated levels. You need to get screening every 3 to 5 years after age 50. Can have diverticulosis, esophageal cancer, gastric cancer, increased risk for these because this IGF-1 is going to be fueling these. Galactorrhea, decreased libido, diabetes mellitus, hyperparathyroidism, hypertriglyceridemia. Hyperphosphatemia, IGF-1 stimulates the renal tubular phosphate reabsorption. Continued discussion on acromegaly. 20-40% of those people with acromegaly have co-secreting prolactin, and co-secrete prolactin makes erectile dysfunction in men and amenorrhea and galactorrhea in women. So the co-secretion of prolactin in 20 to 40% of the patients with acromegaly will cause erectile dysfunction in men and amenorrhea and galactorrhea in women. Now, why do you get erectile dysfunction from the prolactin? Because prolactin inhibits the secretion of gonadotropin-releasing hormone from the hypothalamus. Continue discussion on acromegaly. Best initial test is IGF level. IGF is a protein bound, is not secreted in the middle of the night, so you can measure the levels. Most accurate test, glucose suppression of the growth hormone is the most accurate function test. Glucose should be suppressed. Glucose should suppress your growth hormone. In an acromegaly, if it doesn't suppress, it's because one of the features is adenomous tissue, is it fails to suppress when you give glucose. Confirmation diagnosis, failure of growth hormone to suppress greater than 0.4 within 1 to 2 hours of a 75-gram oral glucose load test. MRI to evaluate pituitary macronoma. If negative, perform a CT of the chest, abdomen, pelvis to measure GH-RH levels. 20% of the population is going to have an incidental, non-functioning adenoma or cyst. And that's pretty consistent in going through endocrinology is images last. And if you look at all these algorithms we do, images last because you're going to find these incidental you're going to subject these patients to unnecessary procedures and follow-up imaging and costs and fear. So we want to first get to clinically, are they requiring this? Then get your measures and measure your labs, then do your imaging. Your imaging is only to confirm a diagnosis that you have. Acromegaly treatment, transsphenoidal tumor resection for cure, but sometimes requires medical management. Remission when IGF levels are within normal limits for age and glucose challenge test results are normal. Injectable somatostatin analogs for those who are not within normal limits after surgery. If that fails, high-dose dopamine agonist if having a prolactoma as well. Pegmavigostigmine is a GH blocker, which also can be used. Risk of tumor growth because it works in the peripheral tissue as an antagonist to GH, but does not decrease the GH production. MRI and hormone tests should be done yearly when the patient is in remission. Treatment should be altered until within normal limits of IGF levels. All right, so the patient has acromegaly, and this is a great board question. Is 2 weeks later the patient presents with acute cholecystitis, what medication was added? So they can do is a really tough question, is they can describe acromegaly as far as the symptoms said they're getting a treatment, and then they're now noted for acute cholecystitis. Very tough question, but this could be a realistic board question. Lanreotide, this is the medication, is somatostatin analog, also considered the same category as a triotide, can be used to pre-op to shrink the tumor, post-op to reduce residual activity of the tumor. 20 to 30% can get acute cholecystitis with long-term use. Lanreotide is a somatostatin to decrease cholecystokinin secretion, which causes gallbladder contractibility and bile secretions, which alters this, decreases gallbladder contractibility and bile secretion. Treatment goal can reduce mortality when getting the IGF close to normal. Surgery success rate in the U.S., they can be very successful, but can have reoccurrence. Remember, microadenomas about 90% in the U.S., and about macroadenomas are, let's go back and say that again. Surgery success rate in the U.S. can have reoccurrence. You can have success with the microadenomas about 90% of the cases, and macroadenomas about 60% of the cases. Pegmazomate, this blocks the growth hormone receptor in the liver, stops the release of IGF-1. Second-line agent, add it to a somatostatin analog if do not have control of the disease. Follow up with GH levels and IGF-1 levels. Bromocriptine, we talked about bromocriptine before. No longer used for acromegaly. Carbocholine leads to less adverse effects than bromocriptine. Carbocholine, approved for those with co-secreting prolactoma. When is radiation used? Is last option. Increased risk of stroke, loss of cognitive function, increased risk of secondary tumors in the brain. PEN, hypopituitarism, can be delayed or happen 10 to 15 years after radiation treatment. This is a 24-year-old woman presents with concerns about irregular menstrual cycles, reporting menses every 2 to 4 months since menarche. She also noted for progressive hirsutism on her chin, lower abdomen, as well as persistent acne. She has a BMI of 32, so it would be considered obese. On examination, she has coarse terminal hairs on her chin and lower abdomen. Laboratory results reveal elevated total testosterone and normal prolactin. Transvaginal ultrasound demonstrates enlarged ovaries with multiple peripheral follicles. What is this? What disease is this? This is PCOS, polycystic ovarian syndrome, in which this is the following 3 features. This is at least 2 of the 3, you need to have at least 2 of the 3 features, clinical or biochemical hyperandrogenism, ovarian dysfunction, typically irregular menstrual cycles, polycystic ovarian morphology on ultrasound, or as of 2023, elevated anti-Mullerian hormones as an alternative to ultrasound. Polycystic ovarian syndrome consists of amenorrhea, oligomenorrhea, and infrequent menstrual signs with signs of biochemical evidence of androgen, excessive hirsutism, acne, male pattern balding, or mild increases in DHEA or indoor testosterone. Is associated with obesity, insulin resistant, frank diabetes, hyperlipidemia, and obstructive sleep apnea. The ovaries and adrenals produce excessive androgens and estrogens, a result of peripheral amortization of the androgens. The continuous secretion of estrogen decreases FSH secretion, but enhances LH secretion, such as the ratios of LH to FSH ratio are greater than 2. The increase in LH causes ovarian stromal hyperplasia, more production of androgens, and it's a chronic cycle. Continued discussion on PCOS. The presence of ovarian cysts as criteria of PCOS is debatable, as patients can have normal ovaries without any cysts. PCOS, it may have small increases in androgens. Serious increases to these androgens in the 2 to 4 upper limits of normal is a tumor of the ovaries or adrenal glands. So PCOS is going to have small increases in androgens. If there have serious increases, 2 to 4 times the upper limit of normal, we need to consider tumors of the ovaries and or adrenal gland. PCOS, the treatment of PCOS. First treatment includes education about weight loss. This is where the GLP-1s can become useful. And there are actually studies on this. And then depending on the degree of hyperandrogenism and whether pregnancy is desired, no hirsutism and no desire for pregnancy, you can get oral contraceptives or oxyprogesterone every 1 to 3 months to induce withdrawal bleeding and to protect the endometrium from hyperplasia. Hirsutism and no desire for pregnancy, prescribe combined estrogen, progesterone, oral contraceptive, and insulin sensitizer such as metformin or thiolindone. Hirsutism and desires of pregnancy induce ovulation with clofidamine or with or without metformin. PCOS, presenting complaints, missed irregular menses, more than 6 weeks apart, hirsutism, and difficulty controlling weight. 10 to 20% of U.S. women meet the criteria for PCOS. The Rotterdam criteria 2003 requires only 2/3 to diagnose PCOS. Polycystic ovaries on imaging, irregular periods, hyperandrogenism, 2 out of 3 of these. Hirsutism, which can be midline terminal hair darkening, coarsening hair, and alopecia. Severe acne with isotretinoin treatment in adolescents. So here, and then the changes are is do not have to get the polycystic ovaries and imaging. You can get anti-Mullerian labs show elevation on anti-Mullerian hormone.